First of all, I'd like to thank Ruan. I kind of adapted his slides from last year for this talk. We're going to talk today about minimally invasive spine surgery, the evolution of it over the years, the various techniques that are out there, or at least a small smattering of the various techniques, as there's too many to talk about in one 30-minute talk, as well as evidence-based outcome measures. So we'll start with the definition, or at least try to define what the definition of minimally invasive spine surgery is, talk a little bit about the history of minimally invasive spine surgery, common techniques, both for degenerative and degenerative spinal disease, as well as deformity, evidence-based outcomes, and then future directions. So even just defining what minimally invasive spine surgery is quite difficult these days. You can see this is an image of Ruan searching for minimally invasive spine surgery last year and showing that there was 10.8 million results in Google. I did an updated search of this year, and now there's 26.2 million results. So it's
that's awesome.
Almost tripled in 1 year. So you can see that this is an extremely popular topic among the public, not just among spine surgeons. So it's something that I think it's important that we continue to better define and provide an evidence basis for what we do. So is MIS a technique? Is it a technology? Is it a product? Is it a surgical approach? Is it a marketing ploy by implant companies? Is it a philosophy, surgeon skill set, or a systems-based approach? I think to a certain extent, it's all of these. And I think, in my mind at least, I think a surgical philosophy is probably the best way to think about it, as opposed to a specific set of skills, a specific approach, or a specific technology, but really the philosophy of doing the same amount of correcting the same problem with less invasiveness and less destruction of tissue. So this is from a previous, is from the spine textbook. They describe an MIS procedure as one by the virtue and of the extent and means of surgical technique result in less collateral tissue damage, resulting in measurable decrease in morbidity and more rapid functional recovery than traditional exposures. And this is important without differentiation of the intended surgical goal. So ultimately, any MIS surgery should produce clinical, radiographic, and functional outcomes that are similar to or better than those of comparable open, more extent cell surgeries designed to achieve the same goals. So just because it's minimally invasive, if it's not able to achieve the goals that we're already able to achieve with open surgeries, then it hasn't really added much to our surgical arsenal, and it actually can result in worse outcomes for patients. So it's something to consider.
Just to give you historical context to that quote, that came actually out of a article, actually a whole issue in Spine. In 2010, Dr. Gunnar Anderson had, at the time, sort of the thought leaders in minimally invasive spine surgery come together in Chicago. So Dr. A and I joined many others from around the world, and one of our charges was to come up with a consensus statement about what minimally invasive spine surgery was, and that's that statement. So, and I think as it stands, I would say it still holds true, which is kind of cool.
Absolutely. And I think it's important to note that nothing in this statement talks at all about a specific technique or a specific technology. It really talks about the philosophy of trying to achieve the same outcomes with less collateral damage is really what it's about. So, and we'll kind of continue to expound on that. So, rationale for minimally invasive surgery. I think one book I've been reading throughout this year is this one that is from Dr. Tumalian at Barrow Neurologic Institute, and I've been reading through it, and it's really as much of it is a technical primer for MIS surgery. A lot of it is philosophical as well, and kind of it tells you explains a little bit of the rationale for all of these choices. So I think it's a good way to think about these things, and I'll kind of continually quote it throughout the talk. So ultimately, the rationale for MIS surgery is that the traditional open midline exposures of the lumbar spine, it requires substantial pressure at the muscle retractor interface, and this has been shown in multiple studies in the past, basically that in addition to actually exposing the bone that you need to expose with the retractor, just to hold the retractor open and keep it stable, you have to have extra pressure on the retractor to do that. And there's multiple studies that show that when the retractors are in place, the blood flow to these surrounding paraspinal muscles goes down considerably immediately next to the muscle retractor interface, as well as even up to 20 millimeters out from that interface. And that even after the retractor is moved, the blood flow does not fully return to normal, even at the 3-hour mark. So this can result in significant morbidity and pain in the postoperative period. So one of the concepts that that is discussed in this book is a concept that Dr. Tumelian kind of invented, and he calls it the Caspar ratio. And it's from an early paper in the 1970s by Dr. Caspar of the famed Caspar pins, who basically was noting that there was substantial collateral damage from the surgical procedures that we're doing, and he tried to minimize that and get it as close, basically create this ratio where the efficiency of a surgical exposure is the best way to think about it is that your surgical target in terms of the area and your surgical exposure in terms of the area should be as close to equal as possible. And so he talks about that as the Caspar ratio. So if you're exposing twice as much area as your surgical target, then your Caspar ratio would be 0.5. Whereas in an ideal MIS world, your surgical target and surgical exposure should be the same, and your Caspar ratio should be 1. So the premise of this is that only a small percentage of the exposed anatomy is needed to perform an open midline operation. However, the remainder of that exposure that we typically do is an inevitable consequence of starting at the midline and moving laterally. So a minimally invasive exposure utilizes almost all of the exposed anatomy for the operation. So it makes the precise positioning of any access port really, really important during this kind of work. The work that's performed at a depth within the muscle should be indistinguishable from its open equivalent. So we should be able to achieve the same outcomes despite the smaller approach. So again, core principles, we should minimize collateral damage to tissues and destabilization of the spinal column and leave the smallest operative footprint after surgery. Achieve bilateral decompression via unilateral approach is something that's often discussed in MIS circles. Achieve indirect neural decompression with our fusion constructs. Reduce the overall stress to the patient, meaning operative stress like blood loss, postoperative pain, etc., and achieve the same surgical goals as open surgery. So for some history, Dr. Wiltse in JBJS in the 1960s and in spine later discussed muscle sparing approaches for bilateral discectomies and pedicle screw instrumentation, which was later named the Wiltse approach for lumbar decompression. Dr. Cambin then described transforaminal routes to herniated lumbar disc herniations, and this again was kind of a paradigm shift of instead of starting from the midline and moving outward, Dr. Wiltse and Dr. Cambin were starting from posterior lateral and moving toward the center. So it was just a total conceptual change in how to approach the spine. Dr. Foley in Neurosurgical Focus in 1999 described the use of a tubular retractor for a bilateral discectomy. These were initially described using endoscopy. However, they were later popularized by Fessler with microscope use for cervical foraminotomies. Dr. Young in 2002 described endoscopic decompression of foraminal pathology as well. In 1982, Dr. Magral described the first percutaneous pedicle screw replacements, and we'll talk about this in a second, what these actually looked like. Dr. Pimenta has kind of been a very influential recent innovator in that he's kind of upended the world of spine in the last couple of decades with the introduction of minimally invasive lateral interbody fusions, and which has been really changing the paradigm once again. So minimally invasive discectomy is probably the most common quote unquote minimally invasive procedure that's performed around the country. It's a really broad term, and it can include both mini open approaches with talar retractors, with tubular retractors, with or without a microscope or an endoscope. So there's a lot of different people who describe their discectomies as minimally invasive, and there's a lot of different ways that can be approached. These are just some images of a tubular version of a MIS discectomy that you can see here with a microscope and a tube. So interestingly, the concept of a cylindrical retractor for use in discectomy actually was described as early as 1977 by Dr. Kaspar, who actually described it in a book chapter on use of an operating microscope. He described a cylindrical speculum for use in minimizing soft tissue trauma during a microscopic discectomy. And this is actually an image from his paper in 1977. Importantly, it was not mounted to a table-mounted retractor, and so it didn't get wide adoption because a lot of surgeons had trouble keeping it stable in one place, and found that it often moved on them. It later was famously described in 1991, 1997 by Foley et al., and they described a really very similar concept. However, once the table-mounted retractors started to become available, the tubular devices became much more widely used. So what's the data for MIS discectomy? Well, there's been a lot of meta-analysis on this, actually a lot of research on this over the years. This is a recent meta-analysis in 2016 that looked at 5 RCTs comparing minimally invasive to open discectomy with 501 total patients. No significant differences in pre and post-operative VAS or ODI scores, dural leak or nerve root injury were found. They did find that there was slightly less blood loss, shorter hospitalizations, and slightly longer operative times with discectomy in comparison. This is a similar study, again, a meta-analysis of 6 RCTs, no significant differences in operative time, leg pain, complication rates, or reoperation. They did note an incidental durotomy more frequently with MIS procedures. Of note, there's pretty heterogeneous techniques among all of the trials, and again, even how different surgeons describe an MIS discectomy is very different in a lot of ways. So these are very difficult to standardize completely. The bottom line is that there's probably not a lot of short or long-term huge difference between MIS discectomy and mini open discectomy with a talar retractor. This is, again, from this book that's kind of a philosophy that I've been kind of looking into, and the author describes the minimally invasive microdiscectomy as beginning the process of teaching your mind how to begin to reconstruct the anatomy at depth from a paraspinal approach, how to stay oriented without the spinous processor or the lamina as reference points, and thus by starting with a microdiscectomy for tubular decompressions, it provides a foundation that then can be built on for more advanced procedures that may provide more significant clinical benefit to patients versus their open counterparts. So the kind of next step in minimally invasive decompressions is a unilateral approach for bilateral decompression, or the so-called over-the-top decompression. this is also described as a minimally invasive laminectomy by a lot of authors. This is a really important development in the evolution of minimally invasive spine surgery, and allows for decompression of the entire canal without sacrificing the midline elements. And this allows preservation of the paraspinal muscle attachments to the spinous process on at least the contralateral side, and if a tube is being used on the ipsilateral side as well. It was described initially by a number of different groups in the early 2000s using a tubular retractor system. However, it can be achieved with mini open techniques as well. Visualization of the ipsilateral and contralateral anatomy is achieved by tilting the operating table toward or away from the surgeon. And so tilting the operating table away from the surgeon really allows the tube to be angled toward the contralateral side and undercut the lamina, as you can see in these images here. This is kind of a conceptual image showing the amount that can be achieved through a small window. If you see on the left of the screen, you can see the window that's required to do a midline decompression of the entire spinal canal versus a unilateral decompression for a unilateral approach to bilateral decompression on the right, which you can see is a much smaller approach window, but that can achieve similar anatomic outcomes. So there's a little more evidence in support of minimally invasive laminectomy versus open laminectomy for stenosis than there is for discectomy. This is a 2016 meta-analysis published in Spine, compared MIS laminectomy to open laminectomy for decompression of lumbar stenosis. They had 5 RCTs and 7 observational studies. A tubular system with microscope or endoscope was used in 7 of the studies, whereas 5 studies were described as minimally invasive but used a mini open approach. The patients in the MIS group had a higher satisfaction rate, 84 versus 75%. They had lower postoperative VIS scores by 2 points, less blood loss, shorter hospitalizations, and lower reoperations, which were 1.6% versus 5.8%. Once the authors sub-analyzed to randomized studies only, this data became non-significant. And again, that's them basically going from 12 studies to 5 studies. So it's difficult to tell whether this is a true finding or whether this was a loss of power that resulted in the significance going away. They did note an 11-minute average longer operative time compared to open laminectomy, and a comparable intraoperative dural injury or CSF leak rate. This is another meta-analysis, 37 studies, 1,156 patients. The primary endpoint, interestingly here, was secondary fusion rate. So these were patients who were undergoing decompression for a presumed stable degenerative spondylolisthesis. And I think this is a really potentially good argument in theory for minimally invasive a unilateral approach for bilateral decompressions, in that the patients that already have a stable spondylolisthesis may be at increased risk of having a destabilizing event from an open decompression, whereas an MIS decompression in theory should result in less bone loss and less destruction to the posterior ligamentous complex, which should in theory result in less instability. And these authors basically showed that may be the case. So they reported a lower reoperation, 5.8% versus 16.3%, as well as lower requirement for a secondary fusion, 3% versus almost 13% in patients with unilateral approach for bilateral decompression versus open laminectomy. They described less slip progression, 72% versus 0% in the paper. I have a hard time believing that they truly had a 0% slip progression even in the MIS group, but that's what they reported. And greater patient satisfaction by a little bit in the MIS group. Again, these are mostly level 3 and 4 studies with a lot of potential for bias, but it does give some evidence basis behind the thought that these may be less destabilizing procedures. So getting into percutaneous instrumentation for posterior elements, the first description of this was by Magriel in 1982. And basically he described essentially an X-fix for the spine. And he used pedicle screws that were then connected to an external fix header. Interestingly, the original purpose of these devices, as described in the literature by Magriel, was to identify and confirm symptomatic levels of discogenic pain by immobilizing them and seeing if the pain got better before a fusion was attempted. There was a lot of limitations to these, including infection, discomfort, obviously the need for removal, and eventual fusion after the devices had been in for a while, and so they were largely abandoned. In 1995, Matthews and Long then attempted to use subcutaneous plates that connected the pedicle screw shafts to try to eliminate this external hardware, but they still required later removal. The subfascial rods that we use today were introduced around 2001 by Foley et al., and they used removable extenders, or kind of the towers that we use today, which were applied to the pedicle screws and allowed for passage of rods. So the premise behind why percutaneous screws are better in terms of preventing collateral damage to the surrounding tissue is that by matching the approach angle of the pedicle screws to the angle of the instrumentation, the surgeon can use either a Wiltse approach or a true percutaneous approach to avoid significant muscle dissection and retraction versus opening up at the midline and retracting all the way laterally to get the angle for a pedicle screw. And you can see the difference between C and B on the image at the right as to why that makes sense. It is important to note that accurate imaging modalities are necessary. So accurate fluoroscopy is the traditional method of placing pedicle screws, and it's extremely important that it is accurate, as the normal surgical landmarks that are available to a surgeon for freehand pedicle screw placement are not as readily available. CT navigation and robotics are changing the paradigm a little bit at this point. They are in theory somewhat less technician dependent. However, they still, obviously, if the array is off or if there's problems with that, it's the surgeon's responsibility to understand and be aware of that. So percutaneous pedicle screws have been used for trauma. This is a 2018 meta-analysis which sought to compare percutaneous short segment pedicle instrumentation to open and short instrumentation for thoracolumbar spine fractures. They looked at 9 studies and 433 patients and found that percutaneous techniques were associated with lower intraoperative blood loss, shorter operative time, and mildly better postoperative VAS scores. There was a non-significant trend toward less adverse events in the percutaneous group with a RR of 0.53. And this image here is just a percutaneous lumbopelvic fixation that Dr. Muntz and I did a little while back for a patient with spinal pelvic dissociation. So this is a great way to essentially provide stability across a fracture while the fracture heals without performing a true fusion. So these even can be taken out at a later date once the patient has fused and essentially be acting as an internal X-fix. So moving along to MIS TLIF. This was first described in 2003 by Dr. Foley, again, using a tubular retractor. The procedure has undergone multiple iterations, and virtually every company has their own version of an MIS TLIF at this time. The traditional way of doing it involves a 22 to 26 millimeter tube, which is passed over serial dilators in a lateral to medial trajectory. to approach the symptomatic foramen. Contralateral percutaneous screws can then be placed for disc-based distraction, followed by disc preparation and cage placement. This allows for both direct and indirect decompression through the same approach, and can be used to treat broad range of degenerative pathologies. The main criticism of MIS TLIF is that the inner body footprint is dramatically smaller than a number of the other inner bodies available to us, and it's much more difficult in clinical practice to restore lordosis in the lumbar spine. There's been several studies that reported improved outcomes compared to open TLIF, including decreased hospital stay, a faster return to activities, and less blood loss. The large majority of the TLIF studies that are in the literature are comparing MIS TLIF to open TLIF, so that's most of the data that we have to go with. The reported fusion rates are from 81 to 100% with MIS TLIFs, and these have been reported to be essentially equivalent to open TLIFs. Pros of this procedure are it's a single position anterior posterior surgery. There's lower soft tissue dissection and blood loss than with open techniques, and that it can preserve the natural posterior tension band of the spine. The learning curve has been described as steep. This can result in increased operative time during the beginning of a surgeon's learning curve, as well as there's significant difficulty treating bilateral symptoms in most surgeons' hands with this procedure. There's also been papers that have shown that radiation exposure is substantially increased with MIS TLIF compared to open techniques. So this is a prospective 5-year outcome data on 83 patients who are undergoing MIS TLIF. The authors found that they used plain radiographs and CT to assess for fusion, and they also looked at outcomes including surgical time, blood loss, and hospital stay. They found that patients improved on average by 35.5 points in terms of their ODI score at 5 years, and they had significant improvements in disability and pain, which persisted. Their overall fusion rate was in the low to high 80s for single level at 5 years. This is basically just showing that this is a viable option. This is another study which was a review of 12 prospective and 17 retrospective studies, as well as 1 RCT. The authors assessed ODI at greater than 1 year, VAS, EBL, length of stay, and operative time. They also evaluated radiation exposure, fusion rates, and complications. They found that MIS TLIF demonstrated substantially less blood loss, decreased length of stay in the hospital, as well as lower complication rates, but did increase the radiation exposure to the patient and to the surgeon. They didn't find any differences in fusion rates or operative time. So at this point, the biggest criticism of TLIFs by most surgeons is their inability to adequately restore lordosis in a lot of patients. And so this is a study kind of looking at a lateral approach or an oblique approach, comparing it to open and MIS TLIF in terms of postoperative alignment characteristics. And the authors basically found that lordosis correction was suboptimal in both open and MIS TLIF compared to OLIF. And the findings were even more pronounced with the L5S1 subgroup analysis. So they actually found that lordosis was decreased, or patients became more kyphotic at their measured level with open TLIFs in general, and that MIS TLIFs at the L5-1 level actually resulted in increased kyphosis, and they only resulted in an average of less than 1 degree of lordosis at other levels, whereas oblique lateral interbody fusions oblique lumbar interbody fusions resulted in 5 degrees on average of lordosis creation and 15 degrees of L5S1 level. So this is these images over here. One of them is the patient I just presented who had 2 TLIFs and ended up with an iatrogenic flat back from loss of lordosis at those levels. And then this is an image the bottom image is a lateral inner body fusion, which resulted in that we did recently, which resulted in a reduction of a spondylolisthesis and increased lordosis at that level. So MIS TLIF is a safe and effective technique for treatment of a variety of spinal disorders. There is a steep learning curve. However, after surmounting that curve, it's associated with better outcomes, short-term outcomes and intraoperative outcomes than open TLIF. There's not a lot of high-quality randomized trials. However, most of what we do have shows that MIS TLIF is probably better than open TLIF. Restoration of lordosis with the procedure remains a major problem. So at this point, we'll start talking about lateral inner body fusions, ALIFs, and indirect neural decompression. So the concept of indirect neural decompression is that without actually removing bone and ligament from the neural elements, we can still take pressure off of them by restoring anatomy to where it should be anatomically. So this can be achieved through anterior and lateral lumbar interbody fusion. So when the lateral interbody fusion was first introduced in 2006 by Pimenta and his colleagues, since that time, this has been widely adopted, and the interest in indirect neural decompression has become widespread in the MIS community. It's been widely adopted and has various names now, depending on the company who's marketing it. The concept is that indirect neural decompression is achieved by increasing the disc space height, widening the neural foramen via increase in the intrapedicular distance, as well as tensioning of the PLL and ligamentum flavum, which results in essential ligament axis and reduction of pressure on the nerves. And you can see in this illustration to the right, you can see that happening via both MRI as well as an artist's picturing, an artist's concept of what that looks like. So we actually do have some data that shows that this happens. This is a prospective cohort of 43 patients, 43 levels, which are treated with standalone XLIF. Pre and post-operative lateral radiographs and MRI were evaluated. Substantial dimensional improvements were noted in all parameters, including disc height, foraminal area, and central canal diameter. But the question is, when is indirect decompression enough versus when do we need to supplement it with a direct decompression? So this came out of our institution. This was a pilot study looking at a retrospective review of lateral interbody patients without direct decompression. The patients are stratified into two groups based on how they answered the ODI question 7, which involves pain while sleeping and resting pain in the supine position. The patients were stratified into group 1, where they reported minimal rest pain, and group 2, where they noted significant rest pain. Group 1, the one with minimal pain at rest, were noted to have achieved MCID for leg pain more often, almost twice as often, and had larger decreases in leg pain, more than twice as much, as well as back pain at 3 months, compared to patients who had significant rest pain preoperatively. So this is something we often use in clinical practice, that if the patients are telling us that their pain is completely relieved with rest, our confidence level that they will achieve improvement in neurologic outcomes with indirect decompression is much higher. One other area that's been looked at are radiographic parameters. This is a prospective enrollment of 45 patients who underwent XLIF. 101 spinal levels were monitored following indirect decompression. There was a 29% failure rate of indirect decompression in this study, and a multivariate analysis of radiographic factors was performed, and the only significant independent predictor of failure of indirect compression in this study was was bony lateral recess stenosis. So this is a case that I recently did with Dr. Mundis, and this patient, we did an anterior lumbar interbody fusion, and I've presented this one in the past, but she ended up having some worsening of neurologic symptoms at one of her nerve roots. We still are not entirely sure what the potential cause of it is, but you can see it just on her MRI that she does have some significant bony stenosis lateral. So that is something that potentially could have given us a clue that we may have been suspicious there may have been problems with that plan. So MIS lateral interbody fusions are still considered controversial by a lot of surgeons, so I don't think it should be anymore. There's well over 400 peer-reviewed publications at this time, several large-scale systemic literature reviews showing that lateral transpsoas approach to interbody fusion is at least clinically and radiographically equivalent to other techniques, and probably is better in a lot of ways. It's a validated and it's a very reproducible technique when done correctly. There's been a number of other lateral approach techniques that have been developed, like oblique interbody fusions, as well as shallow docking techniques for lateral interbody fusions. However, in particular with the shallow docking method, there's limited data to support it with a noted increase in neurologic complications. So this is a paper in 2015 that Dr. Lehman published in the European Spine Journal that looked at a number of, it was basically a review article and a systemic literature review of the complications, outcomes, and economics of lateral interbody fusions. And they had a number of conclusions, but basically they said there is an anatomic justification for lateral interbody fusion, including at L4-5, where there is a lot of concern in the surgeon community about. When the anterior half of the lateral disc space is consistently free of nerves, it can be relatively safe as long as the principles of lateral interbody fusion, like continuous EMG monitoring, are followed. The complication and outcome profiles are acceptable in comparison to conventional approaches, and we have very good data to show that they're similar, if not better, in some regards to other conventional approaches. People often talk about the neurologic risk of the lumbar plexus for lateral interbody fusions. However, the neurologic complication rates are pretty equivalent overall, given the lower risk of neurologic complications in other areas. So, and then the economic viability has been shown in multiple areas. So this was a prospective multi-center study of 55 patients directly comparing XLIF and TLIF that came out relatively recently. It was a two-part study published in Spine in 2016. The take-home conclusions here were that there were more prevalent issues with hip flexor weakness and some sensory changes in the leg following XLIF, but that they had all resolved. TLIF and XLIF were reported to result in essentially equivalent clinical improvements at 2 years, and that patients' neurologic symptoms improved in both groups. Interestingly, they did not find that either procedure was superior for reducing radiographic spondylolisthesis or improving lordosis. However, I think this is the current literature is probably pushing us more toward lateral interbody fusion for this. They found that the disc height and foraminal height were better increased with lateral approaches, and that the TLIFs did improve central canal area slightly through direct decompression. The area increased substantially further via indirect compression with XLIF. It didn't have a substantial difference in subsidence, migration, or fusion rates. However, they did slightly favor lateral interbody fusion. So this gets us to the big bear in the room, the correction of MIS, correction of deformity through MIS techniques. And this is kind of a combination of all of these things. So the goals of deformity surgery need to remain the same as the traditional goals: restoration of sagittal and coronal balance, construction of solid fusion foundation, decompression of the neural elements, and improvement in patient outcomes. There have been several studies that have shown that this is a feasible techniques with acceptable outcome measures out to 2 years. And the goal at this point is to determine which patients are viable candidates for MIS techniques and which are likely to benefit from them over open techniques. So again, these typically involve a combination of anterior, lateral, and potentially transforaminal approaches to disc spaces, with a lot of the correction happening in the anterior column, then augmented by minimally invasive posterior instrumentation. Large focal corrections are typically performed either with mini open PSO or an anterior column realignment. These were typically recommended only for small flexible curves with minimal sagittal malalignment. However, the indications have been expanding. This is a ISSG study looking at 350 patients comparing open versus MIS, and they basically and we found that MIS groups were on average slightly older, had a slightly smaller coronal curve, a higher ODI. They had a smaller SVA, and their PLL mismatch tended to be less than 30 degrees. So you can see that the patients who have huge PLL mismatches, high SVAs, and huge coronal curves were still being treated open. So this is the anterior column realignment, and again, this is a method of achieving segmental lordosis without the potential morbidity of a PSO. Significant lordosis can be achieved once the anterior longitudinal ligament has been resected, which is the main difference between this and a typical lateral interbody. So it's resection of the ALL followed by hyperlordotic cage placement. So the complication rates are high, but they're lower than most reported PSO papers. And the majority of these complications are transient hip flexion weakness or paresthesias. These have become very popular in the last couple of years for restoring alignment versus a PSO. However, it's the indications, in my experience, have been few and far between, as they obviously need an open disc space, and the amount of correction that you can get with an ACR is often achievable is often necessary in the lower lumbar levels, L4, L5, L5S1, which you can achieve the same goals with an ALIF. And if it's fused, then typically a PSO is necessary. So this is a algorithm that was attempted to be defined by the ISSG regarding which patients are good candidates for deformity surgery. You can see it's relatively complex. The bottom line is if they have a fused or rigid spine, they're not a good candidate. And if they have, so that makes them kind of a class 4 patient. So they basically need open surgery in order to fix that. If their alignment factors are not very bad, you can see on the left, then they're a class 1 and they really need kind of decompression only surgery or fusion of a single level as opposed to a full deformity correction. These class 2 and class 3 patients are the ones in the middle who are MIS candidates. Class 3 typically are the ones who need something more expansile, including an ACR or mini open PSO. And those are the patients that have high PLL mismatches and major sagittal balance problems. This is an example that was in this talk before of an MIS case that was successful. So complications include approach-related complications, implant placement and fixation. neurologic injuries in the lumbar plexus or in the dura are possible. Working through a small footprint means that local anatomy needs to be mastered, and these aren't procedures to just jump into lightly. There aren't as many anatomic structures available for reference during the minimally invasive approach, and that surgeons need to adjust to changes in the tactile feedback with longer instruments and less visual cues. Dural and vascular injuries can be very difficult to manage through small incisions, and the disc-based prep can be more difficult and require use of specialized instruments and even fluoroscopy. We're running low on time, so I'm going to kind of skip through this a little bit. There's some studies showing the incidence of Durati in the MIS group is a little bit higher, and that's probably from the learning curve. There's the complication rates in MIS TLIF versus open are slightly higher in open versus MIS TLIF, and then in the lateral interbody fusion research, there's a lot of heterogeneity in the literature on neurologic injury, how this is getting better. There's been authors that have promoted a shallow docking technique with direct dissection through the lumbar plexus. However, the post-operative neurologic complications with this have actually been shown to be higher. So I guess I'll get back into the philosophical mold at this point and talk about the principles of learning MIS. Is really that the midline is the basis of the orientation in traditional spine surgery. And the further we venture off of this midline, the more disorienting the exposure tends to become for us as surgeons. So the minimally invasive approach asks a lot of your mind, particularly with regards to recall memory, not recognition memory. So the concept here is that the surgeon needs to be able to see in their mind what is there, but that they can't see, and that is kind of one of the keys to becoming a good MIS surgeon. And then, of course, minimizing ionizing radiation and not relying on it too much is important for you and your staff. So this is just a model of kind of what a vertebral body may look like in your mind as you're working up the learning curve, and then it becomes more and more detailed as you have more and more recall memory, and that you're able to understand where you are in space without seeing as many cues more and more over time as you become a better MIS surgeon. And this is just a quote by Thomas Paine: "Once the mind is enlightened, it cannot again become dark." And I'll leave you with that. Future directions: robotics, augmented reality, single position surgery, prone lateral interbody fusion are all kind of areas of immense interest that we will not get to today. Does anyone have any questions? If I haven't already left all of you asleep, like my son.
That's a great talk, Dan. It's obviously a huge topic, and I like the kind of focus on principles and philosophy, because I think that's certainly where all of our minds should be. And, you know, as we treat our patients, trying to create the most narrow footprint humanly possible, I think it's really, really important. It's 8:15, so I'll probably leave many more comments. You and I can talk offline if you want, but thanks for a very comprehensive overview.
Thank you.